Welcome back to The Explainer. Today we're diving into a real surgical masterclass, stepping right into one of the most challenging, complex, and frankly fascinating areas of human anatomy. We're looking at the staging and management of retroperitoneal tumors, specifically focusing heavily on sarcomas like liposarcoma and leiomyosarcoma. Whether you're a surgical resident, an oncologist, or just a focused learner who loves breaking down high-level clinical protocols, you are absolutely in the right place. We're going to strip away all the confusion today and look strictly at the data and the surgical guidelines.
Okay, let's dive right into this. You know, the retroperitoneum is very often referred to by surgeons as an anatomical black box. And why is that? Well, because this area at the back of the abdomen is a highly compliant space. It's essentially this giant, flexible void. Unlike other parts of the body where a growing mass immediately bumps into bone or tight connective tissue, down here, tumors can expand massively without hitting any rigid physical boundaries. And this leads to a truly terrifying silent growth phenomenon, where these masses can become absolutely enormous before a patient even realizes something is wrong.
So here is our clinical roadmap for today's explainer. First, we'll cover the anatomical black box, then workup and imaging controversies, followed by the AJCC 8th edition staging, then liberal compartmental resection, and finally we'll join the surgical discussion.
All right, Section 1, the anatomical black box and the silent growth phenomenon.
Because this retroperitoneal space allows for completely unchecked expansion, these tumors are basically master hiders. They don't announce themselves early, with sharp pain or immediate dysfunction like other issues might. Instead, they finally show themselves through direct compressive red flag symptoms. A patient will typically come in with a palpable, painless abdominal mass, which is often shockingly large by the time they even notice it. They might complain of some vague back pain just because the tumor is physically pressing against the posterior wall. Or they'll experience early satiety, meaning they feel full really quickly when they eat. Imagine feeling full after a few bites simply because this massive tumor is physically shoving your stomach out of the way.
Moving right along to Section 2, workup and imaging controversies, as we navigate the diagnosis. Now, what's really interesting about this slide is how we decide to actually look at the mass once it's discovered. It really comes down to our imaging protocols. A contrast-enhanced CT scan is your standard baseline imaging, right? It gives us an excellent wide view of the tumor's structural relationship to all the surrounding organs. But we bring in the MRI when we need advanced tissue delineation and highly specific anatomical mapping. For example, if we need to see exactly how close this tumor is wrapped around vital nerves or blood vessels, you absolutely have to know when to deploy each tool.
But wow, here is where the clinical debate really heats up. In a lot of areas of medicine, if you see a mass, you just biopsy it. Well, not necessarily here. Routine biopsy in the retroperitoneal space is highly controversial because of the terrifying risk of tumor seeding. You're essentially risking dragging microscopic cancer cells right into healthy tissue as you pull the biopsy needle out. Because of that, we rely heavily on indicated biopsies. That means a biopsy is only performed when specific histological confirmation is absolutely necessary to alter the immediate treatment plan. Like say if we're considering neoadjuvant therapy before going into surgery.
Section 3, AJCC 8th edition staging, establishing some much-needed order in the black box.
So, when you're dealing with tumors this massive and complex, rigid rules are required to standardize patient care. The AJCC 8th edition brought some critical, sweeping changes to the table. Most importantly, it specifically separated retroperitoneal sarcomas from extremity sarcomas. For the longest time, soft tissue sarcomas were just kind of grouped together regardless of where they popped up. But let's be real, a tumor in your thigh behaves entirely differently than a tumor wrapped around your kidney. The 8th edition finally recognized that retroperitoneal sarcomas absolutely require their own distinct staging parameters.
Let's actually walk through what those new parameters look like. The new T categorization is now strictly threshold-based, meaning it's all about size. T1 is a tumor 5 centimeters or less, T2 is greater than 5 up to 10 centimeters, T3 pushes from greater than 10 up to 15 centimeters, and T4 is reserved for those truly massive tumors that are greater than 15 centimeters. And remember that highly compliant space we talked about earlier? Because of that space, it's incredibly common for surgeons to encounter T3 and T4 tumors on a regular basis.
So, the absolutely crucial point here is that while size gives us the surgical scale, it's the histology that literally writes the future. Histological grading, specifically using the FNCLC system, ultimately dictates the patient's overall prognosis.
Think about it. You could have a massive T4 tumor that's low-grade and super slow-growing, or you could have a smaller T2 tumor that is high-grade and highly aggressive. The biology of the tumor, its differentiation, its mitotic count, and its necrosis, those are the factors that truly tell us what the patient is up against long-term.
Section 4. Liberal compartmental resection, which is the surgical solution.
I want to make this absolutely crystal clear. Despite all of our incredible modern medical advances in oncology and radiotherapy, here's the brutal truth of the matter. Complete surgical resection, meaning achieving an R0 or an R1 microscopic margin, remains the absolute only curative modality for these patients. If you do not get the tumor out surgically, you cannot cure the patient. Surgery is the absolute linchpin.
And this brilliantly illustrates just how much sheer aggressiveness is required in the operating room. The guidelines set by the Transatlantic Retroperitoneal Sarcoma Working Group, or TRW, state clearly, we favor a liberal compartmental resection, removing the tumor and block with adjacent organs even if direct invasion is not macroscopically obvious. Just let that sink in for a second. The surgeon isn't just carefully plucking out a tumor. To prevent this cancer from ever coming back, they are proactively removing the surrounding anatomical neighborhood even if the naked eye can't see cancer on those adjacent organs at all. To get those life-saving clear margins, high-stakes sacrifices just have to be made. Common end-block targets, meaning the organs that are routinely sacrificed and removed right alongside the tumor in one single mass, they include the kidney, sections of the colon, and the psoas fascia. It's a massive, truly life-altering operation, but statistically speaking, taking these adjacent structures is the absolute best way to ensure the tumor doesn't silently recur in that black box.
Finally, Section 5. Join the surgical discussion on multidisciplinary care and next steps.
Medical science is this constantly evolving debate, right? And these complex cases always require incredibly nuanced, multidisciplinary care. Which leads me to a pretty provocative question for you all. In your center, do you routinely use neoadjuvant radiotherapy for high-grade retroperitoneal liposarcomas to try and shrink it first, or do you just bypass the radiation entirely and go straight to compartmental resection? I really want you to debate this down in the comments below. I read them all, and I genuinely want to hear your clinical perspectives on this. And hey, while you're down there, hit that like button, make sure you subscribe, and tell us exactly what surgical topic you want us to cover in the next explainer. Thanks so much for learning with us today, and we'll see you next time.